Can you hear me? Anybody there? Okay, there is. Okay, wonderful. You can hear and see the screen. Wonderful. Thanks very much. Thank you. Right. I'm just going to introduce Kelechi first again. Okay, hello everybody. Hi again. It's Nnene here. And welcome to the noon meeting organized by the Health Economics Unit. Today we have our MPH student, Kelechi Nnene, presenting her MPH research. Her thesis is currently being examined, and she's going to talk about colon cancer treatment costs at Groote Schuur Hospital. Her presentation will be around plus minus half an hour or so, followed by questions. So I'll see you soon again. Over to Kelechi.
Thanks, Nnene. Hi to everyone in the room and those who have joined us online. As previously introduced, my name is Kelechi, and I have just completed this work as part of my MPH dissertation, specializing in health economics, and I'm excited to share with you. So the topic of the work I'll be sharing on is colon cancer treatment costs at Groote Schuur Hospital in South Africa. And as a background, why did we think it was necessary to even think about this study? Colon cancer, just like every other cancer, it's a high driver of morbidity, mortality, and economic cost globally. As you can see, even beyond Africa, there is prominent incidence and mortality caused by colon cancer. But the situation in Africa is quite delicate in that, irrespective of the visibly low incidence, the mortality to incidence ratio is really high. And this ratio peaks in South Africa with a mortality to incidence ratio greater than 0.9 in South Africa. This definitely highlights that there is a poor outcome of treatments with regards to colon cancer in South Africa. And there are questions in our minds about what we can do to improve these outcomes. You definitely agree with me that to improve these outcomes, public health action or measures are needed. But can we even embark on these measures if we don't have an idea of what resources need to go into them? And every health economist or policymaker would say no, because definitely we need to have an idea of what it would cost to provide the service, to even plan for the service. And unfortunately, there is an insufficient evidence of colon cancer treatment costs currently in South Africa. To the best of our knowledge, this will be the first study conducted in this particular institution in South Africa. Why do we really want to do this? Because we know that if we have reliable cost data, it will definitely help to guide the design, the implementation, and the effective scale of colon cancer treatment programs and prevention in South Africa. Therefore, we embarked on this journey to estimate a stage-specific colon cancer treatment cost at a public hospital in South Africa, adopting the health provider's perspective. What we actually did was to identify the treatment components and link these components to relevant cost items. We also estimated a guideline-based per patient direct treatment and follow-up cost for colon cancer, and we identified the specific factors that drive this cost in the facility. So to our methods, this was an ingredient-based and expert-informed guideline cost estimation. One of my supervisors would call this real world. But yeah, it was an ingredient-based and expert-informed guide cost estimation. It was done at the Colorectal Clinic and the Combined Oncology Unit at the Groote Schuur Hospital. Then what exactly did we do? We spoke to clinical experts consisting of colorectal surgeons, oncologists, chemotherapy nurses, and pharmacists, as well as a few administrative staff, to figure out what exactly goes into the treatment based on what is in the guideline. So we confirmed the information in the guideline. We obtained and quantified relevant cost items for what is required to provide this treatment for an individual patient on average. And we also asked them what would be the patient utilization information. So if we were to provide this particular treatment and we needed these items, how much of this would we need to attend to one patient on average? And then when we got that information, we developed an Excel model and did an accurate bottom-up evaluation. And then we also carried out scenario analysis to test the robustness of our results. For the scenario analysis, we adjusted two models, two factors or two parameters in the model. For the first parameter, we did a variation in the nursing staff cadre based on the annual cost of employment, just to imagine what would happen given the context of tax shifting, where you might not have an expert or specialized nurse, and then you need a more low-level nursing officer to carry out that duty. And then in the second scenario, we carried out a 25% reduction in the post-surgical inpatient days, just to find out what it would cost or the impact it would have on the treatment cost if these patients stayed fewer days in hospital after surgery. So just to unpack the guideline, because this is what the costing is basically based on. So based on the guideline from Groote Schuur for treating colon cancer, for treatment of stage 1 and stage 2 cancer, there is an initial management that involves surgery, the surgical removal of the tumor and the related lymph nodes. And this is usually followed up by no chemotherapy, no adjuvant chemotherapy. And then for the follow-up, there is an annual surgical clinic assessment for 5 years with a carcinembryonic antigen testing. Then for stage 2 high risk and stage 3 patients, you would usually still have the surgery. And then after the surgery, you will go on to receive adjuvant chemotherapy. And for follow-up, you would have 6 annual surgical assessments with the CEA test, 2 CT scans done in the period of 5 years, and 1 colonoscopy every 5 years. And then for patients who come in with stage 4 cancer and is operable or treatable by surgery, you would usually have surgery, but most times and on average, way more than 1 surgery, because you would need to address both the tumor, if possible, and any other sites of metastasis. And then this is usually done immediately or following some perioperative chemotherapy. In the case where this is done immediately, the treatment is followed up with adjuvant chemotherapy, and then you see the follow-up. They have 6 surgical visits, 6 tests, 6 CT scans, and a colonoscopy. And then if you come in at stage 4 and your cancer is untreatable by surgery, you would usually have no surgery for treatment. This doesn't mean you might not have other surgeries for palliative care and correction of obstructions, but based on the treatment for colon cancer, you would have no surgery for removing the tumor. And then you would just go on palliative chemotherapy, and the follow-up is the same as above. So for the capital cost we considered the building space, we considered the equipment and the furniture. And for these, we used an annuitized replacement cost per treatment duration. Our annuity function, we used a 3% rate. For the expected life years, it varied. It was, I think, 30 years for the building, 10 years for some equipment, and 5 years for some electronics and other furniture. And then we got our replacement costs. Some were gotten from Groote Schuur, some were gotten from independent suppliers, and some were gotten from internet searches. So to our recurrent costs, we consider the personnel time cost, per treatment duration. We considered pharmaceuticals, which included the medication and relevant consumables, by multiplying the unit prices by the total patient utilization or average dose. And then, due to the scope of the study, there were some other cost components that we just picked up from the facility service charge or from literature. So mostly for the staging investigations, where you have the tests and the other microbial evaluations, and then for the inpatient admission cost. So we use the fee per service multiplied by the average per patient utilization. We have presented every cost in the South African rand and USD equivalent using that average annual exchange rate. So to our results, we worked out unit cost based on the treatment components. So first, consultations. For the consultations, we have presented the cost for consultations per visit. And we have further split these consultations into the pre-operative consultations and the post-operative consultations. So by pre-operative consultations, I mean the consultations before the patient's surgery, and post-operative consultations are the consultations after surgery has been done. And then we also consider the multidisciplinary team meeting, which feeds directly into these consultations. So for the surgery, we consider the cost for a laparoscopic colectomy, which would on average be the surgery of choice for patients who come in at an early stage. We also consider the cost of an open colectomy, which would be the surgery for patients at the late stage. And we have also worked out the cost for a liver resection, which is on average the most popular site of metastasis. We have also provided the cost for per day stay after surgery, and we have also worked out the cost for chemotherapy, cost per cycle. These are two basic cycles used in this facility, the Calpos and the Capiri. We have also worked out the cost per cycle of this chemotherapy. And here we also present the unit cost for the staging investigations as cost per procedure. So we see the cost for colonoscopy, for the CT, for the full blood count, for the biopsy, the renal function test, and the other tests. So now to the elephant in the room. We were able to arrive at this cost for stage 1 to stage 4 colon cancer. You can see that the costs range from 60,000 South African rands to over 170,000 South African rands for stage 4 disease. We have also worked out the cost for a 5-year follow-up period, and you see it ranges from about 17,000 South African rands to 51,000 South African rands. You would agree with me that this is a significant cost burden, and you would also appreciate the stage progressive cost escalation going on here. So the treatment cost drivers. We can clearly see what is happening here with the risk profiling investigations, the consultations, the surgery, the inpatient stay, and chemotherapy. These were the key components of treatment we identified. And we can clearly see that the cost for surgery was prominently obvious across every cancer stage. In the stages where you see that the cost for surgery seems contributed so much, is mainly because they didn't have need for chemotherapy. So for example, in stage 1 and 2, you see that it looks like surgery contributes more to their treatment, but that's simply because chemotherapy wasn't taking up any share of that cost. So even for patients who do not need chemotherapy, the cost of surgery is still evident and contributes massively to the treatment. Then we also noticed something else going on with the inpatient days post-surgery. These, if we had added to the cost of surgery, would have driven this cost way out of the roof. So we can see that the cost for inpatient stay after surgery is also noticeable and prominent across the 4 cancer stages considered. So for our scenario analysis, so for the first scenario, which was the alternative staffing scenario, there was a decrease in our base case cost, even though this decrease is not as much as what we have observed with the second scenario. But with the second scenario, which is a 25% reduction in our postoperative inpatient days, we find out that there was an average saving of over $170 per patient for the stage 1 to 3 patients, and we see an average saving of over $500 per patient for the stage 4 cases. So just a few conclusions and some key takeaway messages. There is a significant per patient cost burden for treating colon cancer in this facility. There is a stage-specific treatment cost that increases with advancing cancer. There is need to prioritize early diagnosis because that is the only way this cost can be reduced from what we have seen. Surgery and postoperative inpatient days have been identified as the major drivers of this treatment cost across all the 4 cancer stages. This means we have to do the homework and implement or look for strategies to make surgical procedures more efficient. We also see from our scenario analysis that a reduction in the number of inpatient days after surgery may reduce the treatment cost. There are protocols that have been established that could be used in addition to surgery to enhance surgical post-operative days. We would like to say that these protocols might really be implemented and utilized in this facility to reduce this treatment cost. Just like every other research, this one is not without limitations. So we have only been able to explore the cost for colon tumors, excluding the rectum cancer, which is a broader component of the colorectal cancer. We have also been able to only present our costs based on what the experts have told us with regards to the guideline. Yes, we may argue that this is not, real world, but at least it gives us an idea of what is going on, even real world. And then it's also limited due to the assumptions and possible variations in treatment that would happen in the real life scenario. We have also excluded certain key components of cancer treatment, such as palliative care and the management of recurrence and treatment complications in our costing study. Early cancer diagnosis doesn't just save lives, it saves money and saves the economy. I would like to acknowledge my supervisors. Their contribution has been substantial to both my personal growth and my success with this research and the masters as a whole. I would also like to acknowledge the African Awareness of Cancer and Early Diagnosis, of which I am a scholar. And I also like to acknowledge the Health Economics Unit that has provided me with the admission and this time to share and learn. Thank you very much.
Thank you, Kelechi. Very nice presentation. I'm going to leave it on. Okay, so again, thanks very much, Kelechi, for a really clear presentation and good luck with your examination. So I'd like to start with the audience online. If you have any questions for Kelechi, please go ahead. Okay, no questions at the moment. So we have our large audience here in one of our seminar rooms. So I'd like to go back to you, who actually made an effort to come and be here in person. Do you have any questions for Kelechi or any comments? Mademoiselle, please go ahead.
Thanks, Nnene, and thanks, Kelechi, for a very good presentation. You're a great presenter. And very informative slides as well, like nice slides. I have two questions. So the first question is, how did you measure personnel costs? And that's more from, I'm doing a study and I just want to understand how you measured your personnel costs. Was it just from the expert interviews, or did you actually sit and observe time motion study? Or yeah, what strategies did you use for that? And then what informed the second scenario of your scenario analysis, the 25% reduction? Was that literature or, yeah, thanks.
Can go or do you take on questions?
No, I think you'd rather go. We'll take one question at a time.
Oh, okay. Thank you, Pada. Thank you very much. So for the personnel cost, using the bottom-up approach, it was a bit tricky to work out the personnel cost, but this was what we did. So obviously, we know the personnel in question and their cadre, what we are looking at from the interviews. Then we got the cost to employment document from Groote Schuur. So there you have the annual salaries. So we take an average. So for example, let me answer you clearly. So for a specialized nurse, that's a chemotherapy nurse, we take her average annual salary and then we divide it by her productive working hours per year. How did we arrive at the productive working hours? We took note of their leave, their annual leave, and then we took note of the national public holidays. Yes. So what we had left, we divided that by the annual salary. Do you understand? So we were able to work out what is the per hour pay or what for this personnel when they are doing productive work. Due to the scope of the study, we couldn't go in to carry out the time and motion, which is a very practical way of determining this. But this was what we did. So when we find out what a nurse's pay, that nurse's pay is for 1 hour productive work, then we can walk down for one patient that comes in for chemotherapy, she attends to this patient for, let's say, on average 3 hours, which we also got from the expert interview. Then we were able to work out what cost it is for that. And then to your second question, yes, even before I stumbled on the literature, I was just curious because, yes, it was informed by literature. Let me answer your question. Because there is literature on the enhanced recovery after surgery study in Groote Schuur that shows that a 25% reduction in inpatient stay, that adopting the enhanced recovery after surgery protocol could lead to a 25% reduction in inpatient stay. So this was basically informed by that. But even before I stumbled on the literature, I was already thinking, because what I was told by my supervisors was to find out those components of treatment that are not necessarily core, but tend to contribute to the costs. So I was already looking at the inpatient stay before I came across, and that led me to the literature, which informed that scenario. I hope.
No, I think I understand. Yeah, thank you.
Thank you, Kelechi. Other questions?
I know this was beyond the scope of your study, but how much do you think it would cost to implement that protocol? If you've seen the protocol, like, do you think it would cost less to implement that protocol compared to what the status quo?
Yeah, it will be, if you mean, I think it will be cost effective just by once off looking at the cost, I think so. Because they actually do it at not a large scale, they actually do it at some scale in Groote Schuur. So what it means is you prep the patient before surgery. I should have actually costed it, but just given the scope and the timeline I couldn't go into costing it. But I think it would definitely make sense cost effectively.
Yes, go ahead.
Thank you, Kelechi.
Sure.
I love the presentation. So I have a question. So you didn't cost palliative care, right?
No, I didn't.
So I'm just curious, from your own perspective, assuming you added that to your costing, do you think it could have reduced the costs, especially at the higher stages?
No, it should have actually increased the cost. The reason I didn't include, I saw literature that had worked out the palliative care cost at Groote Schuur, but the reason I didn't include it was because the guideline was a bit not clear about the palliative care. So if I had seen specific components of palliative care listed out in the guideline, I would have spoken to the experts about it. So for example, to say if a patient came in with stage 4 cancer, what would their palliative care program look like? If I had gotten information like that from the experts, then I would have been able to work out what the palliative care cost would be. But it would definitely not, if you mean cheaper in terms of cost effectiveness, maybe, but if you mean cheaper in terms of overall cost, no, to definitely add to the treatment cost. Because palliative care provision is like another treatment. There are personnel involved, they're using their own space. Sometimes they even do the ICU, so it would have added to the treatment cost. Except I didn't get your question.
Yeah, you did. I'm just thinking, for example, for a stage 4 patient, some patients, they would opt not to go for curative treatment because it has no benefit. So they go for palliative care. So in such an instance, I was thinking that perhaps that could lead to lower costs.
Yes, we did cost palliative chemotherapy. What is stipulated in the guideline, which reference to your question, is just the need for palliative chemotherapy. So patients that come in with stage 4 disease that can't be operated on, they go in for the palliative chemotherapy. And we did estimate that cost. It's about 51,000 rands, thereabout, for their palliative chemotherapy package. It has about 4 cycles of, I think altogether between 6 to 8 cycles of the two different regimens. That's what it's for. 8 to 12 cycles for the palliative chemotherapy. And after that, they don't continue. They either see if you're going into remission. If you don't have good prognosis, they stop. If you're going into remission, they move you to supportive management.
Basically, going the palliative care route, the colorectal cancer care would be a cost-saving option. However, the fact that you excluded palliative care for those stage 4 cancer cases means that there will be actually extra cost to that. So what Dennis is saying makes sense, but you didn't compare that. That was not the aim of your study. You weren't looking for the stage 4 cancer treatment options, palliative care only versus treatment plus or without palliative care. That wasn't your objective, but something you could, obviously your thesis is under examination at the moment, but I thought you could bring, if you were to publish this research, is in your discussion, you would bring these issues up and try and make sense out of them and say that your study did not look at those alternatives, but would be agenda for future research. Yeah. So you did the work looking at different treatment options in hospital, excluding palliative care for 4 stages of cancer. But this would be a very interesting question also to look at, because that can also reduce the cost of treating stage 4 cancer. Which now takes me to the question of, if I may, question of the protocol. So your study shows that early diagnosis is the key, because it is much less costly to treat a stage 1 cancer patient than stage 3 or stage 4. So what would be the reasons for late presentation in terms of the health system? I mean, is it something that you reviewed in the literature?
Yeah.
And what would be your recommendations based on your data from the study?
Okay. So from the South African literature, which was not much, we found out that there are delays with the care seeking. So even before they present, and in most cases, this is alluded to the symptoms of the disease, which marks as a symptom of so many other conditions. So someone would say most of us would bleed annually once or more in our lifetime, but we don't have colon cancer. So most of the patients go on with these symptoms masked as other things. So there is a patient delay. Then there is also the health care delay, where to reach the diagnosis also takes time off the patient's time, even though they have presented to the hospital. So these are the two major things I found out from literature. But what I would suggest from my findings is that there might be need for more strategic screening programs, because with the screening programs, now we are not guessing what could be the cause of the blood in the stool or the constipation. We're actually going to find out what this is. And if we can, as they have done in the West, track genetic histories and family histories so that we can know the specific patients that need this screening. So we don't have to all wait until we are 40 or 45 or even 50 to go in for our first colonoscopy. And then there are also other tests that have been introduced that can be easily adopted, like the fecal. I don't exactly know what it's called, the immunofecal stuff. So it takes the physics and it tests for the presence of some antibodies that could be markers to show that there is colon cancer. So these are things I would recommend if I was speaking to a policymaker, because then we know exactly that even if it's not colon cancer now, there is going to be colon cancer. So you come in for more frequent screening, and then we're able to catch early and address it at a lower cost.
Thank you.
Assuming we're all from the Department of Health, why should we invest in colon cancer compared to all the other cancers? With the higher.
It coming. I saw it coming. You said Department of Health. I knew you were going there. Yes, even if it's not cancer, one disease is not better than the other. But what we must appreciate is that every disease is a burden, comes with its own burden. And I think for me, why I got passionate with colon cancer and colorectal cancer was the fact that it's so prevalent and not a lot is being done about it. Yes, breast cancer is prevalent, and I would like to believe that quite a lot is being done about it. Cervical cancer is prevalent, and definitely a lot is being done about it, even the catastrophic health expenditure costs, So this is also prevalent. Why are we quiet about it? And it's obvious with even though that was not specifically South African data from the global can, it's obvious with the mortality to incidence ratio. So what does the mortality to incidence ratio of 0.9 mean? It means that the possibility of surviving colon cancer in South Africa is less than 10%. That's terrible. So even if the incidence is not up high there, if there is one incident case, then we're going to lose that case if nothing is done about it. I don't know if you understand. So it's just the need for us to do more, talk more about this particular cancer. That was my passion. And I'm grateful that you're not from from the Department of Health.
If I can just add to this, which is great. So the cost analysis is a really good starting point.
Yeah.
But it doesn't give us the full story, it just gives us the picture of the cost. What we would need to look at in order for us to, at the Department of Health level, decide on which cancer, which other disease we may want to invest more in, we would need to look at the cost effectiveness of treatment for cancer versus treatment for something else. And then look at the cost effectiveness ratio to see what is the better value for money. And then be advised also by the burden of disease. Obviously, we have millions of people with one particular disease. We're going to focus on that, particularly if treatment for those is more cost effective. So we will be guided by both the burden of disease and the cost effectiveness, which now leads me to a question relating to the cost analysis, which is a good starting point. something that you would do after you've done cost analysis of this nature is a budget impact analysis to say, okay, so this is where we can save, but now what kind of impact would that have on the budget for colorectal cancer? And to do that, you need to have the numbers of those in need. So what do you know? I mean, maybe you don't have any numbers at hand. What are the numbers of patients for each stage of cancer that we can assign to these unit costs? So in other words, that is the question. Do you know how many patients were treated at stage 1, how many were at stage 4? Just to get a sense of the proportions.
I don't know how
Plus
many,
minus.
but I did ask the clinicians, the experts on average, and it's 15 for stage 1, about 15% of the patients they see, and 25 for 2 and 3, and the rest
Is stage 4.
I did ask all the physicians I spoke to. I just didn't bring it into the costing because it's not concrete data.
Yes. So that would be very informative if you could bring those numbers in relation to the unit costs and show how not only is the stage 4 cancer most expensive to treat, and not only that, but basically there's no way back. People eventually die at stage 4 cancer. So those costs are sunk costs. We've already invested in people, but there's no way that they're going to get better. Not only is it more expensive to treat, but also you have 50% of the cases that present themselves at stage 4. So you have the highest number of cases to be treated, plus it's the cost of treatment. So those would be really interesting exercises going forward. Whoever's going to take it from here on, maybe you as a researcher may, and that you feed into budget impact analysis, which would be your next step.
Sorry, I have a question. Yes, the budget that should be at national level.
The burden of disease will be at national level. Yeah. This is more just the frequency or utilization at the hospital level. In terms of how many the cases require care. But the burden of disease is at national level.
So for the budget impact, if the number and the proportion that we get at the hospital that we did the data collection is different from what we get from the national statistics, which one should be?
The national you use. So basically, what is the population in need? So let's assume we need to know for the colorectal cancer, what is the number of registered cases of cancer, what is the last year? At the national level, different stages, or just generalist cancer. We will say, okay, there were 200 cases of colorectal cancer. So our population in need is 200,000. But obviously you cannot perhaps reach the whole 200 a lot, then you can vary that. So you would use that, not the facility level cases. And obviously there is a population need, but there's also those who will be the compliance rate, or those who could be reached, the coverage rate. You can never cover 100% of people because a lot of people will not present. So you won't be able to provide them any treatment because they present maybe at a very late stage when there's not even palliative, the last few days of palliative.
Do you think there's value in a country like South Africa where provincial departments have, they have their own health budgets? So doing the budget impact at a provincial level as opposed to a national level, is there value in that?
Oh, absolutely, there is. So you will start, so it depends what the burden of disease indicates to show. Often it's national level as a general, and then you can break it down into provinces if you want to look at that. And then we'll use provincial level data for the provincial budgets.
Yeah, because I'm assuming the strategies would also be different per province based off of the fact that they have different budgets and
different healthcare systems. Put it that way, especially in South Africa.
Yes. But if you want to look at how this introduction of, let's say, new technology for this treatment, for this disease, would impact on the overall budgets or on the overall public spending, then you would look at the national level spending. We say, for us to change the protocol will impact on the budget in this way, and it will reduce the budget spending by an X amount at the national level. Not the aim of your study, but this is starting point.
And so, sorry, just one last comment is, I think your study can also lay the foundation for justifying the role of AI for the surgical interventions to reduce the costs, right? I mean, now we're still very much at a developmental stage with using AI for surgeries, but I think that would be maybe in high income countries, not yet here, because it would be expensive, but I think, you know, it justifies why we need AI to reduce those personal costs, which I'm assuming are a huge cost driver for surgeries.
Yeah.
Yeah.
But yeah, just like you said, I did speak to the colorectal surgeon. They have the robots. It's very expensive.
Maybe not cost effective.
Not at all.
Oh,
Yes.
Yes.
I have a small question about screening. So I understand South Africa, we have a policy for screening for breast cancer and cervical cancer. So I'm just curious, is there a screening policy for this cancer, for a lot of cancer?
I don't know if it's South African, but I know there is a, I think 45 years old colonoscopy provision for some medical aid. I don't really know how the health system works in SA, but I know that there is this provision where from 40 to 45, your medical aid provides a colonoscopy screening.
So it's essentially private patients.
Yeah, we might want to put it that way, but you know that almost every patient is being funded in one way or the other in South Africa. So I know I don't know if it's a national guideline. I honestly do not know, but I know that almost all the medical aids have that provision. I think it's either 40 or 45 years. Then you are entitled to one fully covered colonoscopy. I don't know if you know more about that, Lydia.
I don't. I'm not sure what the age group is, but that's only in the private sector. I think Janice's question was public sector. I don't think there is a public sector policy on colorectal cancer screening.
No, I don't.
But there is one for cervical cancer. I know that, which is for women, obviously age 40, 50, and 60.
Yeah.
And you have that free of charge every 10 years.
Yes.
Not sure about breast cancer in the public sector either, but I would imagine that may be linked to clinical physical examination. But colorectal cancer, I don't think the public sector covers, and there is policy for screening. But the private sector has that policy, and the cutoff age may be 45. Sure. Yes, please go ahead.
First one, speaking from the health perspective, it's they do screening colonoscopies if there's a family history of previous cancer. So mainly they wouldn't just screen any random person. Now the other one is from a certain age cutoff, because like the risk factors are maybe in the 70s or so. So they don't do, I think it's 1 in 10 years from things like 70 and older. But definitely if there's family history, then we will do regular screening based on my factors are.
In the public sector.
Oh, okay.
So if I get the debate on the index patient, so there is a patient who comes with cancer, is diagnosed with cancer, then they would follow up with their family members. If there is gene or not.
Yeah, because like
There's
things
a
like the line follow condition, it's a very, I think like 90 or so people who have that condition will eventually get cancer, but it's not sort of 1 or 2 percent. Those people eventually get.
Very interesting.
Yeah.
Yeah, but I have actually different, thanks very much for that. We have a clinical background. Yeah, always helpful.
Yeah.
Question, Kelechi, you started off by saying people die from colorectal cancer. Why don't we, something should be done to provide better care to save more lives? And then you went on doing cost analysis to show how the costs could be reduced, which is fine. So we can either save or treat more cases. But how is that linked? In other words, my question is, why are there so many cases of untreated cancer? And why is the cost relevant? It's not that those cases are left untreated or don't survive because there are no resources available to them or they are denied the care. That's not the case. Probably what it is, and I'm not sure, I'm just trying to understand and you can maybe share with us. Is it just because of the late presentation stage?
Mostly, yes. Largely, yes, because it's quite treatable. Yes.
So then back to your research studies, results. Yes, you can save on cutting on inpatient days, and maybe you can do other things to cut costs. And you do that, and then maybe use those saved resources, or maybe resources come from somewhere else, to do something that is more important, which is to get patients screened earlier. So once you say something is, well, we can reduce costs, but then what do you do with that information? To change the situation, which is finding more cases. Something that also would be helpful for your discussion if you publish in this work.
Yeah. Thank you very much.
Because ultimately that's what you want to do, is ultimately we want to save lives by providing the most cost-effective care. And just cutting down on inpatient days by 25% doesn't mean that, we'll still have the same mortality rate in the end, unless the patients are denied care because there aren't resources, because the care is so expensive.
I think it's more about the advocating for screening. I think it's more about advocating for something to be done so that these patients come in earlier.
Yeah.
And so they are treated better and have better outcomes. That's more about it.
Yeah. So what are the screening options besides the colonoscopy? Are there any less invasive screening options that could be done at the clinic level early on, like symptoms based?
Yeah, there is the fecal.
Yes.
Yeah, I don't know what it's called. Fecal immunochemical.
Yeah.
I don't know if you know about it.
Okay.
So they just take the stool.
Yes.
And they take it to the lab and test for some biomarkers. There is also most of them are invasive. They do screen for the polyps, which is pretty invasive as well. Yeah.
Yeah.
And family history is something else I know they use very well, especially in the West, because most of the papers I came across are not from here. So they do the family tree thing. So if a patient comes in with colon cancer, they make sure that especially the primary relatives, is that what they are called? The immediate relatives are now booked up for the more regular screens. Yeah.
Yes. Wonderful. I don't know why I haven't seen you burning with it. So I mean, I'm just every now and then checking down questions online.
So, for most other cancers, right? Well, not most, some other cancers, for example, with breast cancer, we know to check for lumps, etc. Right? And I don't know a lot about colon cancer. Then from you, and you've spoken about bleeding and the stool, etc. Right? That the patients can look out for, but like you said, it's common. People with hemorrhoids, for example, they also have blood in their stool.
Yeah.
Are there any other signs or symptoms that the patient themselves can look for or can be aware of? So, for example, if we wanted to run a program on like the radio, for example, to say, check for these things, and if you have these things, then you should go to a clinic. Apart from blood in your stool, what else is there that a patient can check for that would also allow them to go and seek help earlier? Does that make sense?
Yes, it makes sense. The thing about the manifestations of colon cancer is that it varies depending on what section of the bowel where the tumor is. I don't know if you would agree with me. I'm just speaking off what I read from the text. So if the tumor is on the right side, or on the sigmoid, on the lower part, close to the rectum, your symptoms differ. So it's really very tricky when it comes to giving a list of symptoms. But the basic things I would advise anyone to look out for is unexplained constipation. And unexplained is that your diet is balanced, but there is constipation. And obviously the bleed is there, but unexplained constipation, fatigue, anemia, unexplained anemia, because most times you bleed internally and you don't even know. But you bleed at an upper part of the bowel, and by the time those two comes out, you don't really see the red blood in it, but the decomposed blood is in it. So anemia, weak fatigue, constipation, and just any lower bowel disturbance that is unexplained. Yeah, those are the symptoms I would advocate anyone for.
So great. So we're now on the solution seeking part. So what could be done more or less but in relation to your data, because what you can do with your cost is not necessarily, oh, now let's cut down on what you do in the hospital, because maybe that's not going to help. It's using your cost data to show how expensive it is to treat colorectal cancer at any stage, particularly stage 4 cancer. Therefore, so you showing, your data is showing how expensive it is to treat cancer at different levels. And then with that, you're saying, well, we need to do something about it.
Yeah.
To reduce the cost of treatment and obviously save lives, we need to bring those patients in sooner. And then some ways of doing that would be through obviously not just colonoscopy, which is expensive, unpleasant, and how do you get people to get the colonoscopy? And it's also, expensive in any setting. So there must be other ways of doing that. So these kinds of discussions would be very useful. Detecting early symptoms and then awareness and education. So you have a radio show, you say, well, if you notice these signs, then maybe go to the clinic. So you're using your cost data to say how expensive it is to treat cancer. Therefore, something needs to be done to get us diagnosed earlier. I think it's wonderful. I don't think this work has been done before, to the best of my knowledge. So well done.
Thank you.
Okay, we're almost coming to an end. Really good luck, and
Thank you.
try and publish this with
I
your
will.
supervisors.
I will. Thank you.
It can be very informative. Thanks, everybody.
Thank
Thank
you.
you.
Bye, everybody.